So, good evening, all our esteemed members of Maharashtra Ophthalmological Society, the members who are joining from at large, who are from all corners of India, from AIOS also. But most importantly, this goes out to all our young stars, our postgraduates who have joined us today to learn the pearls that they are supposed to learn as a part of their residency program for not only their examination, but I'm sure that all these pearls are going to help them a lot in also their practical learning and in the future also for their practice as well. This is a session which is, I'm sure, going to be very inspirational for our young stars. We have stalwarts who are going to mentor you and they are going to take you through today's session. We from the scientific committee of MOS are thankful to Dr. Sumit Lahane for coordinating all this series throughout the year. He has done a fantastic job. And now I would like to welcome and I would like to request our Honorable President, a very, very dynamic and people's person, Dr. Santosh Agarwal, sir, to please give his welcome address. Over to you, sir.
Thank you, Vardhaman. Respected teachers, seniors, my colleagues, PG friends, a very good evening to one and all. I welcome you on behalf of MOS for this unique PG grand round in which we are going to have case presentation by our own PGs and how to take the history, how to examine the patient, how to put forth their findings, and then our stalwarts, the experts in the cornea, they will throw light on the different aspects of the corneal diseases. So everybody will learn from all these discussion, and especially PGs, because in their exams, practical exams, they have to face different questions, and this will definitely help all our PGs. So our purpose is to give the practical training to our PGs, because the theoretical things are available. There are so many resources nowadays. YouTube, online, Google platform is there, but practical training is must. So this will definitely help the PGs as well as our practitioners to refine their knowledge. I thanks once again Dr. Sumit, Dr. Vardhaman and scientific committee team, my MOS team, and all the participants, including PGs, all corneal experts from different parts of the India, and also MOS faculty, and everybody who have made this PG program successful. Thank you so much, and over to Vardhaman again.
Thank you very much, sir.
Vardhaman, again, I forgot the quote of the day.
Yes, yes, sir.
For everybody, for especially for PGs, concentrate all your thoughts upon the work at hand. The sun's rays do not burn until brought to a focus. So you should be focused on your studies and whatever you are doing. Thank you so much.
Yes. Yes, thank you, sir. What a wonderful quote. And I think the focus changes the aspect of learning. And I'm sure with this uh, webinars, the postgraduates are going to have a very practical approach towards their exams. We are very thankful to both the national faculties as well as the MOS faculties for joining us today, who are going to take our postgraduates, hand hold them, and actually teach them the nuances. This month has been dedicated to cornea. So, this is the second webinar for our postgraduates in the specialty of cornea. And now I would like to welcome Dr. Sumit Lahane, who is the chief coordinator for this series. Over to you, Sumit, to take it forward. Thank you.
Thank you, sir. Good evening, everyone. And I would like to thank our MOS body, Santosh sir, Atul sir, Vardhaman sir, and Aditi ma'am for using this platform and giving the opportunity to PGs all over Maharashtra to have such beautiful webinars. So we do as per the subspecialty every month, and this month the subspecialty is cornea. This is our second webinar in the cornea subspecialty, and today to present we have Dr. Vishakha and Dr. Monica. Dr. Vishakha is a postgraduate student from Bhaktivedanta Hospital, and Dr. Monica is from Cooper Hospital. We do have their mentors with us, Dr. Charuta Manke ma'am, who is the head of the department of Cooper Hospital, She has a very keen interest in PG teaching, and she's the one who is responsible for developing a state-of-art hospital in a Cooper hospital. Thank you, ma'am, for being here. We also have Dr. Sapna Kini, ma'am. Ma'am is a cornea consultant at Bhakti Vedanta Hospital. She did her fellowship from Arvindai Hospital, and she is doing as a postgraduate teacher and very keen interest in PG teaching again. Thank you, Sapna ma'am, for being here and mentoring our postgraduates. As a panel, we have Dr. Nishita ma'am. She does not need any introduction. Ma'am is a senior most consultant at PD Hinduja Hospital, and she is the founder director of our EBCRC, which is fondly known as Bachchu Ali Eye Bank, which provides not only corneas, everything from amniotic graft to the eye drops, serum, eye drops, everything. And thank you, Nishita ma'am, for being here. And we have Dr. Yatish sir. Dr. Yatish sir is a senior cornea surgeon in Narayan Netralaya, Bangalore. I can just say that he is my mentor and he calls himself as an eternal student of cornea. And he is one responsible for increasing my interest in cornea every day. Thank you, Yatish sir, for taking out time. And to
My
moderate
pleasure, Sumit.
yeah, and to moderate the whole show, we have Dr. Asmita Patne. She is our young, dynamic cornea surgeon from Maharashtra. She is practicing in the Kolhapur district and she did her fellowship from Lions Hospital. I would like to thank Asmita especially because we gave her very short notice to prepare for everything and she did it in a her wholehearted manner again. Asmita, over to you, and we will start with Dr. Vishaka's presentation first.
Thank you very much, Sumit sir. Thank you for that introduction. And it makes a little easier for me when you did mention that I did have very little time to prepare for this. Thank you. So, without wasting any time, let's straight away begin with our first case presentation. That's by Dr. Vishaka Patil. Vishaka, you may begin.
Yes, thank you. First of all, I would like to thank everyone for giving me opportunity to present in this webinar. I will start the case, ma'am.
Yes, please. You can make it full screen and go ahead.
Yes, ma'am. Yes, ma'am. Here, I will start with my case. A 17-year-old girl, resident
Full
of
screen. Vishaka, try for full screen. You can press that red button down there.
Is my screen is not full? Okay. Now my screen is visible, sir?
Yeah,
it is
completely.
full?
Yeah, it's great now. Go ahead.
Thank you. A 17-year-old girl, resident of Bhayandar, UG student, came to the OPD with chief complaints of pain in left eye since 15 days, white opacity in her left eye since 15 days. On history, patient was apparently all right around 15 days back when she developed pain in her left eye, which was sudden in onset, gradually progressive, and pricking type in nature. She also noticed white opacity in her left eye since 15 days, which was sudden in onset, initially smaller in size and gradually increasing, associated with redness, watering, and diminution of vision. She also gave history of dust particles going into left eye while playing around 15 days back, after which the symptoms started, for which she consulted her family physician and used the treatment as eye drops containing gatifloxacin plus prednisolone acetate 3 times a day for 12 days. And she also used lubricant eye drop 3 times a day for 12 days. There was no history of similar episodes in the past, no history of contact lens use. There's no history of swimming or bathing in ponds, and there was no history of fever and rash. There's no past history of diabetes, tuberculosis, asthma. In the family also, no one had the similar complaints in her family. On general examination, patient is conscious, cooperative, well-oriented to time-placed person. Rest vitals within normal range. Then the systemic examination parts, all the systems were normal range, including the random blood sugar level, which was 103 milligram per dl. Then the ocular examination, patient maintained head posture and facial symmetry. The extraocular movements were full, free, and painless in all the gazes. Then the ocular examination part, I will start with the right eye. Then the base corrected visual acuity in the right eye was 6.6. All the anterior segment and posterior segment findings in the right eye were in the normal range, including corneal sensations, corneal transparency, Ruppler's test, fundus examination, and IOP. I'll start with the ocular findings in the left eye, which was BCVA in the left eye was 6/12, not improving with the pinhole also. Then the eyelid adnexa examination, upper lid was showing edema, lower lid was normal. Ruppler's test was negative, conjunctiva showing ciliary congestion. Then bean-shaped grayish-white lesion. Now I'll share my screen. Here we can see I have draw a pictorial diagram, and her slit lamp photograph is also showing the bean-shaped grayish-white lesion located infero-nasal quadrant surrounding the paracentral and peripheral zone of the cornea. It had ill-defined margins with the feathery margins, which is also looking dry in base, extending up to the mid-stroma, then measuring about 6 into 3 millimeter in size. Then after application of fluorescein stain, it was stain positive. That was indicative of epithelial defect, and the measurement of epithelial defect was also same to the stromal infiltrate. So on the basis of history and the clinical examination part, my differential diagnosis here become fungal corneal ulcer, bacterial corneal ulcer, and viral keratitis. And my provisional diagnosis was right eye with a normal range, where left eye was moderate, showing moderate grade peripheral non-complicated fungal corneal ulcer. Then I investigated her with the corneal scraping. And then I did the stains for the gram stain and KOH preparation. On gram staining, there was no organism seen, but on KOH preparation, there was fungal element seen. So the provisional diagnosis became more confirmed that it was a fungal keratitis.
Okay.
Yeah.
Uh,
That was a good case presentation, Dr. Vishaka. I could hear the palpitations, but you were much confident and it was good, came out with a good flow. So may I request the mentors and the panelists to ask the questions?
Charulata ma'am, any questions for her?
Yeah. Hello, Dr. Vishaka. That
Hello.
is a good presentation of your provisional diagnosis, which is a fungal corneal ulcer. So I have some questions to ask of you.
Yes,
What
ma'am.
are the other stains that you would use to diagnose confidently that it is a fungal corneal ulcer?
Ma'am, other than the KOH, potassium hydroxide, there are some stains like GMS, Gomori's methylamine silver stain, then periodic acid chip, pass stain, and we can use for the fungal staining, ma'am. Other than this, we can also Giemsa stain can show the fungal staining.
Okay, and since I noticed that when in your history it was saying that they have also given a prednisolone. Is
Yes,
there
ma'am.
anything for topically prednisolone was given by the family physician? Is there anything specific you would like to elaborate on that important point? And related to that, what are the signs suggesting a worsening of corneal ulcer?
As she was treated with the prednisolone, gatifloxacin plus prednisolone. Basically, steroid will worsen the fungal corneal ulcer. So there was initially symptoms were less. That is the she was not complaining of pain in the initial period, but after the starting the treatment, the pain, watering, redness, and diminution of vision was increased, suggestive of there is a progressive fungal ulcer related to her treatment, which was not improving with that treatment. And
Okay, good. So immediately after she came to you, you must have stopped the
yes, ma'am.
prednisolone acetate.
Yes, ma'am.
Now, what are the other clinical signs that you may encounter in a fungal ulcer which may help you in coming to the diagnosis?
Okay. Other signs suggestive of fungal ulcer like hypopine, ma'am. Then the hypopine will be thick and fixed. It will not mobile. Other than this, there will be satellite lesions in case of fungal keratitis. Um, so There will be endothelial plaque in case of fungal keratitis. These are the signs other than stromal infiltrate and stromal edema.
Okay, good. Also, can you tell us which is the landmark clinical trial on fungal keratitis?
Yes, there is a MUT, MUTT, mycotic ulcer treatment trial 1 and 2. Both are done in Arvind Eye Hospital, man. MUT 1 trial, the conclusion was like, basically they compared the topical effectiveness of topical voriconazole with the topical natamycin. But after the trial, it was concluded that effect of the topical natamycin was when treated with the filamentous keratitis, like most of the fusarium species had better outcome with the natamycin than voriconazole. That was MUD 1, and MUD 2 was they compared effect of the oral voriconazole on the topical antifungals, but the outcome was not so effective after addition of oral voriconazole. It was like same.
I'm sorry, you said effect of oral voriconazole on topical. What did you mean by that?
Topical antifungals, systemic addition of systemic voriconazole on the topical antifungals.
And what was the result?
Not such great. No better outcome was with the voriconazole, ma'am. There was some same effectiveness, but with the voriconazole, there was some systemic side effects they have observed.
So, what did you do for this patient?
I added treatment in this case, ma'am, natamycin 5%, topical eye drops, then cycloplegic homide 2%, BD for 10 days, and I added painkiller also. That's tablet Combiplam for BD, twice dose for 10 days, ma'am. Then she improved around 8 to 10 days. She was improving in within 4 to 5 days, and there was a complete improvement within 12 to 14 days, ma'am.
Very good. Thank you. Does anybody else? I'm done with my questions, Dr. Sumit.
Okay, I think Asmita must be having some questions for panel. Asmita, you can unmute. Vishaka, you can stop your screen sharing.
Yes, sir.
So, digging a little deeper into this, taking the discussion further and asking a few questions to our expert panels and the mentors. So, my question here is if it's a deep stromal infiltrate which is not amenable to scraping, how would you proceed in a case like that? Would you opt for biopsy, or would you see how the case is responding and then go ahead?
Yati, sir?
Yeah. Regarding this pertinent question of the presence of a deep keratitis, we at our center are fortunate to have a confocal microscope. So most often, if it is not amenable for superficial scraping, we try to use the confocal microscope and look for the presence of signs of fungal keratitis. But if not every hospital or every center could afford to have a confocal microscopy at hand, in such instances, I would rely more on my clinical skills based on the adequate history, and rely on our clinical sense of acumen and manage the condition. If it is not responding, obviously the gold standard would be microbiological examination or a histopathological examination. So I would still prefer to do a suture biopsy if it is deep seated, or if there is presence of hypopion or endothelial plaques. I wouldn't hesitate to perform an AC tap and subject it to his microbiological examination.
So, would you also add intracameral? What would the role of AC wash or intracameral antifungals, even in cases where the hypopure is not responding?
Yes, every situation is not the same. It depends on the grades of the keratitis. The current case which is being discussed is quite, I would say, early to moderate. It's not at all severe. And such cases respond very well to topical medications, antifungals itself. And coming to the deep-seated ones, the question which was raised, management, of course, first would be the investigations. That's why I stuck on only to the investigations part, as we thought it's only with clinical acumen, or we can do the suture biopsy, and of course AC tap, as I've always said. And when it comes to the initiation of medications, deep-seated ones are quite tricky. The medical management would still be, I would prefer to debride the epithelium over the presence of the keratitis, and try to initiate a lot of natomycin, because natomycin works well when there's epithelial absence over that particular area. And I would combine it with the intrastromal injection of voriconazole. If there is presence of endothelial plaques, then I would definitely try to give intracameral voriconazole. But it's easier said than done, because this would necessitate multiple sittings of intracameral injections, which come with their own, disadvantages. A patient could have, inexperienced hands, could end up having certain complications like hyphema or perhaps even cataract. So I would be a bit wary on giving multiple intracameral injections. But yes, in cases which are not responding, I would definitely look at intracameral antifungal injections. Of course, what type of injection depends on our clinical sense of acumen, and if we do get the microbiological support, it would either be intracameral voriconazole or amphotericin B.
Thank you for sharing that, sir. Regarding intrastromal injections, the next question would be, what are, because it's been quite commonly practiced now, so what
Yes.
are the indications, and more than indications, what are the contraindications for this intrastromal injections, and how many, what would be the interval between the injections, how many is there any maximum number until when you see the response and then go to the next step?
Yeah, sometimes these intrastromal injections could be a bit fancy, because there are definitely indications to when the intracameral injections of voriconazole needs to be given. There's a fantastic paper by Ames, which I'm sure many of you would have gone through. But then that's a good paper. But then we need to titrate and alter on tailor make the intrastromal injections for every case. Now, as I also already mentioned, the deep-seated infections would definitely require intrastromal injections, and those which are not responding to topical medications would require intrastromal injections. And those which are deep enough, almost close to the endothelium, I would definitely prefer to give intrastromal injections. Intrastromal injections need to be given surrounding the edges of the ulcer at all 360 degrees, and I prefer to do it many times in the theater. And if theater is not available, I would also give intrastromal voriconazole at the slit lamp itself. There is no bar on the number of times which intrastromal injection needs to be given. Based on the clinical response, I would titrate it. If the response is good, I would continue for perhaps 2 or 3 more injections. But if the response is poor, and if there are signs of entry into the Decimex membrane, I would definitely think of, and again, it depends on the size of the ulcer. If it is involving the visual axis, if it's a large ulcer, let's say encompassing the entire cornea, I would look to early, therapeutic deep anterior lamellar keratoplasty.
Thank you, sir. Nishita ma'am, would you differ, or any of the points would you like to add, especially the intrastromal injections and the intracameral approach?
I think Yadish has covered it brilliantly. Don't think there is very much that we need to add. Like he referred to the paper by Namrata. They are looking at providing, they've done a study with the Natasol, which is only 0.01%. And we look forward to that being available soon for use intrastromally.
Ma'am, one last question, which is of more practical application, is after the infiltrate is healed and you see the scarring, there are cases where the hypopyon is still not resolved or it doesn't go. So how long do you actually continue the antifungals once you see the lesion is scarred?
I would say my rule of thumb would be at least 2 weeks. After I feel that everything is settled, I would go on for 2 weeks. Of course, the frequency would reduce, but 2 weeks would be the ballpark figure. Waiting for it to become completely dry.
And if the case has to be posted, the same eye or maybe the other eye has to be posted for a cataract surgery, so what is the advised suggested interval once it's all healed?
Once it's healed, I would definitely like to do a sac syringing. Rho plus has to be negative. Make sure that all your all other reasons for infection are also looked at, like your peri-orbital, your nose, your ears, your teeth, and everything is clear. You're really looking at how you would deal with if the visual axis is involved, you're looking at a one-eyed, so be very, very careful. And proceed as per plan. Especially look at how advanced the other eye cataract is.
So here, one practical question is asked by Atul sir. Atul sir has written that when exactly the intrastromal ozol should be given, and what are
I meant to ask is at what stage we should think of going to that. See, if you have a case in a routine OPD with a fungal ulcer, initially we start with the standard, we scrape it, send for the weather, and then we start on as the KOH comes within filamentous fungi or within natamycin and all those. But at what stage we should think that if the ulcer is not responding after 2 weeks or maybe after the first 5 days only, if it is not getting response, should we directly shift to the intrastromal? That is what the message I want the expert should give to the, and I would like to know.
Basically, start with monotherapy, then you add your second drug. Again, you wait to see what is happening. Is the ulcer size increasing? Is it involving the limbus, the sclera? Is it going down to the endothelium? And that's when after the second therapy also you feel that it is still an ulcer that is not responding and you're not still thinking of a therapeutic graft. I think at that time, before getting into the surgical options, intrastromal should be looked at. And I think all medical line of treatment should be exhausted before you actually look at the surgical options.
And one more question, ma'am. What is the role of the oral itraconazoles? When do we start from the beginning only along with natamate, the treatment, oral treatment, mostly, or do we wait for the things to, if it is very hypopyon is there, if you find an endothelial plaque, only in those cases we should give this oral azoles?
I just think I'm not very fond of oral antifungals. The toxicity can be quite high. So I would first exhaust all my topicals, my intrastromal, my intracameral. Okay. I'm not very fond of doing oral antifungals.
Thank you.
So we have only 1 minute left before moving on to the next.
I think here just that if you find that a fungal ulcer is not responding and you're not gotten much on your KOH, remember that everybody must in this particular scenario think of pythium. I think that's one diagnosis that should not be forgotten. And a lovely paper in our IJO by Dr. Baga on when to consider pythium, because the KOH will give you an idea that this is pythium and the clinical signs will give you an idea that this is pythium and not just a fungal keratitis, but an oocyte that is involved.
One question to Sapna ma'am here. Ma'am, you are at the place where you will be getting a lot of referrals and lot of patients who are treated at multiple places and then coming to you with the large corneal ulcers. And it becomes very difficult when patient is already on antifungal and then you do scraping, it may or may not come positive. Ma'am, your guidance for the same. Like, do you stop the antifungal for 48 hours and then do the scraping, or you just continue the same?
We see such scenarios, but for fungal ulcers, I think need not stop the antifungal because KOH will anyways pick up dead fungus also. So KOH will anyways come positive. So we practically have never been required to stop the antifungals before scraping. For antibiotics, yes, if it's not coming, then it's better to stop for 48 hours with close observation, and then you can re-scrape the patient. Antifungals, I have not required to stop it.
So, Smita, can we move on to the next case?
Yes, sorry, I got disconnected. It's bound to happen when you live in a smaller town. So, moving on to the next case by Dr. Monica. Monica, can you please share your screen?
Yes.
And best of luck.
Thank you, ma'am. Good evening, everyone. I'm Dr. Monica Shahare, postgraduate in Cooper Hospital, and I'm presenting a case under the guidance of Dr. Charuta Manke, Head of Department, and Dr. Amrita Ajani, Associate Professor in Cooper Hospital. Chief complaints: a 46-year-old female came to ophthalmology OPD with the diminution of vision of right eye since 1 year, right eye more than left eye. She is also complaining of diminution of vision of right eye post 2 months of cataract surgery and complaining of intermittent pain in the right eye. History of present illness: diminution of vision was progressive, gradual in nature since 1 year with bouts of intermittent right eye pain. Complaining of right eye diminution of vision post 2 months of cataract surgery. Patient had good vision post-operatively. Past history: history of right eye cataract surgery done 2 years ago. There is no history of redness and no history of trauma in past. Treatment history, family history, personal history were not significant. General examination was also unremarkable. Systemic examination is also unremarkable. Ophthalmic examination, head posture, facial symmetry, and eye alignment were normal. Extraocular muscle movements were full and free in all directions of gaze. On examination, the visual acuity done on Snell's distance visual acuity chart. Right eye, best corrected vision, finger count 1 meter. On pinhole, it's not improving. Left eye, a best corrected vision is 6 by 6. On slit lamp examination, I would like to start with right eye. Late conjunctiva were normal. Cornea showing bulle, stromal edema, gutte with no stromal scarring. Anterior chamber were quiet. Pupil, normal size, reacting to light. Iris a normal pattern, and lens pseudophakia. Left eye, lid and conjunctiva within normal limit. Cornea showing gutte. Anterior chamber quiet. Pupil, normal size, reacting to light. Iris normal pattern. Left lens, clear lens. We can see on right eye there is a bulle and stromal edema and no stromal scarring. With the left eye, the gutte were shown. On fundus examination, right eye showing hazy media with hazily seen disc. Macula and foveal reflex were not appreciated. Left eye, clear media with 0.2 CDR, NNR healthy, rest within normal limit. On B scan of right eye, PCIL in situ with retina on. My provisional diagnosis is right eye pseudophakic bullous keratopathy, secondary to Fuchs endothelial dystrophy, and left eye stage 1 Fuchs endothelial dystrophy. Investigation were done, specular microscopy, right eye error, and left eye specular microscopy was done. And treatment plan, in right eye, the medical treatment were given, hypertonic solution and or 5% NaCl, bandage contact lens, and surgical, she's awaiting the DSEC surgery. Left eye medical treatment, rho kinase inhibitors and hypertonic solution, 5% NaCl. And the other treatment modalities in the Fuchs, endothelial dystrophy, the medical management, and the surgical management. Medical management, rho kinase inhibitors, hypertonic solution or 5% NaCl, BCl, and surgical management, anterior stromal puncture, phototherapeutic keratectomy, subepithelial fibrosis. If there is a subepithelial fibrosis, we can go for the penetrating keratoplasty. If there is no evidence of fibrosis, we can go for the DSEC or DMEC. Thank you.
Thank you, Dr. Monica. May I request Dr. Ma'am to ask the questions?
Hi, Dr. Monica. Nice presentation.
Good evening, ma'am. Thank you.
So, your case had a post-cataract corneal edema, right? So,
Yes, ma'am.
you diagnosed it to be Fuchs by looking at that eye or the other eye?
Other eye, ma'am.
Other eye. Okay, so how do you examine for the gutte? Without a specular, can you look for the gutte in routine examination?
Ma'am, on 3-time examination in the 40 magnification in my specular deflection.
Good, good. Okay, so in this case, what are the management options for the right eye?
Ma'am, medical management, the hypotonic solution and BCL. With the surgical management, we can go for the DSEC or DMEC.
Okay. So, and what about PK?
No, ma'am, as there is no subepithelial fibrosis or stromal fibrosis, so we can go for the DMEC or DSEC.
Okay. And for the other eye, what precautions, if it has a cataract, what precautions you would take in a case of Fuchs? While doing
Ma'am, 6 monthly follow-ups for that patient, and the rho kinase inhibitors with hypertonic solution, mainly the medical management.
No, if you plan a cataract surgery when the cataract develops, what would be the precautions that you need to take in the case of Fuchs?
Ma'am, we can use the cohesive viscoelastic substance for the surgery, and the phacoemulsification in the low phaco energy, and phacoemulsification in back, and the IOL with the help of viscoelastic substance.
Type of viscoelastic substance will you use?
Ma'am, cohesive, and we can use the combination of cohesive and dispersive viscoelastic substance.
Dispersive. You want to coat the endothelium, right?
Yes.
And what is a triple procedure?
Ma'am, there is the keratoplasty with the cataract extraction with IOL implantation.
Okay. So, how will you monitor whether the endothelium is worsening or not if you don't have a specular?
Ma'am, by the corneal, central corneal thickness.
The pachymetry. Progressive pachymetry will indicate that whether your endothelium is worsening or not. Because in with corneal edema, if it is severe, you will not get specular images. Good, good.
Yes. Thank you, ma'am.
Else wants to ask?
All right, so we shall proceed with the questions to our dear panelists and the mentors. So, we were talking about the triple procedure, I would like to know, Dr. Nishita ma'am, what is your threshold if you have to plan it, if you have a case of Fuchs who has to undergo cataract surgery? So, when would you go with only cataract surgery, and when would you plan a triple procedure straight ahead?
So basically, I would first of all, when I see Fuchs, I would first tell a patient that early cataract surgery would be better for this patient than later, because the amount of energy then used during the surgery is going to be lower. Because counseling is going to be a very important part of the entire planning of surgery. I am not very aggressive again for triple procedures. I would rather do the cataract surgery first. And then I have seen that several, unless they're very advanced Fuchs, several patients are able to maintain reasonable corneal clarity for quite a while. So it can be done as a second procedure. One of the tests that I use is that if I find that the epithelium is loose, and I do that using a dry cotton bud on the cornea, and I find that the epithelium is loose, then I would say that we would prefer to do a triple procedure in these patients. That's my sort of a quick examination of a patient of Fuchs clinic. But largely, if I look at the number of patients that I have done of Fuchs, it's not been triple. Out of 10, I would possibly look at maybe one that required a triple procedure. But my threshold for doing triple is much, much lower than doing it one after the other. Maybe Dr. Yatish is availability of tissue is also not easy. Tissue availability is also easy, so perhaps that also becomes a point where we have to consider finish one cataract surgery and then look at the next by putting them on the waiting list straight away.
Yes, I would generally agree with you. And also, we can't generalize every case, whether they would require a triple procedure or not. Every case has its own merit and demerits. I've had cases which I've handled on either sides of the scale. There have been cases wherein I've done triple procedures, that is phaco with DMX on the same sitting. But on the other hand, I've also managed only with cataracts. I'm basically extremely conservative as a surgeon. And unless it is absolutely essential, I would defer triple procedures. And again, it depends on the age of presentation of these cases. I've had some elderly patients, especially ladies, whom I've been following up without doing a keratoplasty and having done only phaco, and they've been doing reasonably well with a vision of around 6/24, best corrected, and they're pretty happy. And with both their eyes of having 6/18 and 6/24, they're well off, but they are in their 70s or late 60s, and I wouldn't risk doing a keratoplasty for them. All said and done, keratoplasty is uncertain as a procedure, though we may have fancy surgeries like DMAC, DSEX, and whatnot, but we certainly can't guarantee the outcome of the surgeries for them. So I would generally prefer not to do a triple procedure unless it merits. But otherwise, I would definitely want to go ahead only with the cataract first, and then look at how the corneal endothelium behaves, and then take a call as a secondary procedure. Especially since cataract surgery also, it depends on the type of grade of the cataract. The more dense the cataract is, more inflammation it is, and then it could be deleterious to the corneal endothelium as well, or the graft as well.
So, would your opinion be the same irrespective of the PACI, even if it's like 750, 800, or if the patient is symptomatic in terms of patient does say that he has blurring of vision in the morning? If he does give that history, would you still opine the same? And any role of OCT and topo in monitoring these cases?
I would definitely discuss with the patient, and I would let him know the pros and cons of the triple procedures, and separating the surgeries. But if suppose the patient is one-eyed and he's already having symptoms of bullous keratopathy in the advanced stage, and also cataract, and visibility of the lens also matters. If the visibility of the cataract is difficult, and I would then probably combine both. And there are times where I've done open sky triple procedures as well, because the visibility is quite poor. It depends on the stage of their presentation. But if visibility of the cataract is good, and the bullous keratopathy or the corneal decompensation is mild to moderate, I would still prefer only the cataract surgery first, and then assess how the endothelium behaves and holds after the cataract surgery. It again depends on how we do the cataract surgery. The more meticulous we are with the cataract surgery, and more beneficial for the corneal endothelium. So there are probably it's very difficult to say, how each case has to be dealt with. Generally, we certainly can't generalize. Every case has to be, treated with its own merit. And most importantly, we have to discuss with the patient, let them know that what are the pros and cons of triple procedure or, separate surgeries. Coming to your other question, sorry, it was on topography and OCT. I am not a big fan of topographies in such cases which involve advanced fugues. I would OCT also ASOs ASOCTs though we do have, but I don't use them very often. I would differ. I would rather believe on my clinical skills. And ASOCTs, yes, they do give some amount of additional information, but then I rely more on my clinical skills.
Ma'am, would you like to add anything on this point, the role of OCT and topo?
No, I do not rely on that at all. It's mostly on clinical and chair time for the patient, and very, very, very conservative.
The problem starts when, after explaining all the pros and cons, the patient says, "Doctor, तुम्हीच ठरवा काय करायचंय ते." So when we have to ultimately take the decision. What has been your experience with ROCK inhibitors, which are the new kids in the market?
So if you're asking me for ROCK inhibitors in fugues, I do not find that I've been very impressed with the use of these ROCK inhibitors. Tried them for the first 2 or 3 years, but I did not feel that I got any. I did not feel in the sense that the patients, I could not assess that they were staying stable or not. Because as you know, fugues can stay with good vision and clear corneas, even if the endothelial cells are reduced on your specular. So ROCK inhibitors for me I use only when I see stromal edema post-cataract surgery. I will use that twice a day for a month or so. And I find that is the only one indication of ROCK inhibitors in my practice.
Also, sorry.
Degenerated cells, apoptotic cells do not regenerate according to me, but injured cells, there may be a role of ROCK inhibitors in injured cells or inflamed endothelial cells post-surgery.
In the interest of for the PGs, I would like to ask, if a patient is not willing for surgery and they just want the symptomatic relief. So when we talk about anterior stromal puncture to be done in these cases, so if you can add some for the PGs, like how do you prefer doing the procedure? Do you do it in multiple 3-4 sittings, and how do you manage these cases? Or do we have any other option other than anterior stromal puncture for only symptomatic relief?
I think anterior stromal puncture is a very good option, but you have to explain to them that this precludes any visual recovery by doing a lamellar keratoplasty, because eventually everything gets fibrosed. One thing that I have learned is, sometimes we used to just sit down on the slit lamp and do an anterior stromal puncture straight away for the patient, after, of course, explaining to them, and you do it with a 26 number bent needle. But now I actually will prime the cornea with betadine as we would do a surgery. Because we had one fungal infection post ASP. So after that, I've learned my lesson that I won't do it just by putting anesthetic drops. So one just message that don't take anterior stromal puncture lightly, because you're actually puncturing the tissue, and sometimes you may get your hands burnt on that. But I would do it in number of sittings. Yes, I would not do it all together. We'll call the patient back, and And it is a continuing process. Sometimes you feel you've covered everything, but a new bulle will break open somewhere else. So they know, these patients know, and they will come back. But overall, I think that they get a lot of symptomatic relief. But the visual aspect is obviously something that they have already agreed to lose. The vision.
Just to add on quickly, if I may, when we have seen that anterior stromal puncture, even as Madam told, we prefer to do it even in OT because of these complications. And another thing that we have now is a tattoo gun, which we use for tattooing. If we use it without the ink, so that also helps in puncturing the stroma. So that also we have tried, and it has been useful. So it is also a easy and effective method in doing that. And in Arvind, during our fellowships, we used to even do a Bowman's cautery after removing the epithelium, and with the ballpoint cautery, we used to do the Bowman's cautery like our PRP marks. We used to get all over the stroma, and that would also help to prevent the recurrences in such patients who just want symptomatic relief.
Good idea.
Here, I would like to add is before I move on to the next question, is if we have a case like this, like what Dr. Monica beautifully presented, is one eye presents with corneal edema post cataract surgery, and other eye you do see signs of fuchs. It need not be corneal decompensation straight away. It's very important to rule out a Descemet's detachment, which is underlying, which could be dealt with, and edema could be resolved. So my question here to the panelists is, how would you differentiate these different corneal edemas when it is because of raised intraocular pressure, or it's a stromal immune mediated viral keratitis, or it's decompensation because of fuchs? Some clinical signs for the
basically epithelial edema. If it's there only epithelial edema, the first thing they should rule out is raised intraocular pressure. So that is the first thing. Then other eyes should be examined in detail. Like if they are gutte and all, we get signs of fuchs in the other eye, then we can think of fuchs. Then OCT is a must in non-resolving post-cataract corneal edema, so that we see rule out Descemet's membrane detachment. And so that should not be missed. So that is very important. Then we should also know if we can get what type of surgery it was, whether post-cataract surgery patient could see for some time and then later he decompensated or the vision dropped, or it was immediately, to rule out whether it was a traumatic cataract surgery, a complicated cataract surgery, or it was decompensation later half in the late pseudophakic bullous keratopathy. So these signs we have to see and then come to the diagnosis.
So I have a question here, especially for Charuta ma'am and Atul sir. Both of you sit at some high volume places, and I just want to ask two questions. Do you feel that the specular is must for all cases? Because we might miss gutte at a times. And secondly, what cases of fuchs, like if you suspect and we have or we may not have a specular, do you prefer doing a phaco or you prefer SICS in those cases, even if the grade 2, grade 3 cataract is there? Charuta ma'am and Atul sir.
I can go first. So we get a lot of fuchs in different stages. So it depends on stage of fuchs and stage of cataract also. As of now, we still don't have specular microscope. But sometimes if we feel that, we have to counsel the patient, and it is easy to counsel the patient with the help of imaging, then we do get it on rent. And we can do that if the cataract grade is slightly higher and the fuchs seems to be bilateral and it could decompensate, because we need to tell them that even if we do the surgery today and it's uncomplicated, down the line they may still have a decompensation for that. We have OCT, so we do ASOCT, but I feel in terms of the amount of fuchs that we are having, sooner or later we should be getting a specular, and that will help not only for our PGs, also to counsel the patients and to see what is happening. As for the cataract, if the gray, I also with agree with Nishida madam that we try to do a early cataract with phacoemulsification is the most preferred way, with good viscoelastic and a good counseling and short period of time. So that is what we prefer. Even for, but if there is a little hard cataract, then I have also done. Uh, Using less time, done SICS, small incision with a good visco continuously at every step, and the patients have done well. But some patients, in fact, as somebody said, that it has been missed in that eye because of the volumes, and then we check the other eye and we realize that the decompensation is due to fugues which was missed in the other eye. So now we are actually training our PGs more and more to look specifically at cornea for fugues. Yeah, that's what I would say.
Atul sir?
Actually, Sumit, see, whenever in the pre-cataract profile, in the optical biometry report, whenever I see the corneal thickness is more and more, so I then again have a look whether I'm missing the fuchs or something like that. If at all, I am suspecting that we don't have a specular here in Amravati. So it depends now if the patient is affordable. I'm a single practitioner, so I give him a choice. Either you have to go to Nagpur. Also Nagpur, only one center had a specular microscopy. So it's as the madam said, counseling is the most important. If you don't explain to the patient that these are the possible things, even if you had a good vision, you might get deteriorate afterwards, or even if the surgery is going perfectly okay, still you had a problem post-op. And if we had a talk with the patient, they understand the points. I do have two cases. I operate with the help of a cornea surgeon with the combination that simultaneously with the dissect and the phaco, this sort of things that had been. Even I refer the patient, if I give the choice to the patient whether you want to go to a higher center or something like that, because this is the problem. And to avoid the post-operatively hassles and all these issues, mostly I feel counseling plays a very big role in such patients, because otherwise, if we don't say pre-operatively, we'll land up in trouble post-operatively. That is what.
Thank you, sir. Actually, that reminds me that now that we have got the optical biometer, it's very important that we, which sometimes we are missing, that, look at the Paki since we don't have specular, and then keep in mind and recheck again.
Yeah, that's
right. Dr. Asmita, next segment.
So moving on to the next segment, that's where I will share certain 2 case scenarios, and we will learn from a panelist how do we deal with such scenarios. Is my screen visible?
Yeah, very much. You can make it full screen.
Okay. It is appearing full screen to me. It's not there.
Play.
Yeah. Okay. Right.
Yeah, now fine.
Our first case scenario is a 36-year-old female who has good vision in both eyes, complaining of redness, watering, and pricking pain in her left eye since last 15 days. She gives history of recurrent similar episodes since last 2 to 3 years, for which she has been taking treatment, which resolves and then comes back. She also has similar episodes in the other eye intermittently. She has been, for this episode, she's currently using moxifloxacin, natamycin, acivir, everything. So when you have a look at the cornea, you see small round infiltrates. You see one at 1 o'clock position, and there's a small one at 3 o'clock position with a clear zone between the limbus, and you see some vascularization around. On staining, the fluorescent staining is minimal. And when you have a look at her eyelids, which could have been missed easily if not looked for, you do see that there is significant blepharitis. So what will we do in this case, and how would we proceed with the diagnosis and the management? So as we understand here, it's a clear-cut case of marginal keratitis. That's what we think is non-infective. So my question would be, what are the differentiating features clinically from differentiating this sterile keratitis from an infective keratitis? Nishita ma'am or Yatish sir would like to take this question.
Yatish, you
Yes.
want to...
Yeah. Please proceed, ma'am.
No, go ahead. Go ahead.
Yeah. These marginal keratitis, usually they can be differentiated whether they are infective or non-infective. Infective ones usually land up having an epithelial defect, while the inflammatory ones, non-infective ones, do not usually have the epithelial defect. And the presence of a clear lucid interval goes more in favor of a non-infective one. And I wouldn't usually, if they're very tiny ones and present typically at, let's say, 2, 4, 8, and 10 clock hour positions, I wouldn't usually scrape them for microbiology. And I would definitely give a lot of prominence for maintenance and clearance of blepharitis, and especially the antibacterial ones, and thorough cleansing and keeping the eyelids clean. We also use these wet tissue wipes, which have tea tree oils nowadays. These were not, available earlier many years ago. These seem to be playing a good role in maintenance of blepharitis. And regimen of steroids, yes, if they are infective, which are more often whitish in color than yellowish, which are more in favor of an infective ones. Which, if I'm convinced they are more inflammatory, I would definitely put them on topical steroids. If they're very tiny ones, small ones, I would prefer to use even fluoromethalon, because fluoromethalon is one steroid which is not potent. And if it's very close to the topic or epithelium, they would make do with fluoromethalon itself, or my next choice would be dexamethasone and antibacterial cover.
Sir, what would be your how would you taper the steroids? How long would you keep the steroids? Because that is a very common question, whether to start at 4 times, 6 times, and do you do a slow
Yes,
taper?
it again depends on the adjacent conjunctiva, the presence of congested vessels there. Those definitely are a telltale sign of inflammation. So they are a clue. Once the vessels start reducing in their intensity and the less fierce they become, that is a sign when we know that we can start tapering the steroids quick. And I, for one, I'm not a very favorable guy for utilizing steroids for a longer time. So as soon as the inflammation comes down and the epithelium heals well, if at all, if there's anything, and the size of the infiltrate comes down, and if it starts to scar, I would soon taper the steroids. I would usually start at 4 times a day and gradually taper once in 5 days, or at max once in a week. And 4-3-2-1 5 days taper is my choice of tapering of steroids.
Ma'am, how would you manage these chronic cases of blepharitis? Would you add a plain antibiotic or antibiotic with steroid? And would these special scrubs like tea tree oil would be at your first treatment itself, or only you will reserve it for cases who are not responding or are recurrent despite the treatment?
So if you're only looking at the lids, Asmita, lid hygiene has to be taught to the patient. And just telling them lid hygiene is not enough. Actually, we in our clinic, we actually will demonstrate it to them and explain to them both with diagram and an understanding of what is actually happening at their lid margin. We take photographs so that they can see what their lid margins look like, compare with the other eye. And lid hygiene regimen would be warm compresses, either with an eye mask or with hot water fomentation. Then we show them that the massaging has to be done from the nose to the ears. And after that is done, then they need to wash it. This if they could do this twice a day, it would be good. We do use Johnson Baby shampoo we do tell them to use Johnson Baby shampoo to wash off all the things that have, all the secretions that have come out of the meibomian glands. And now we get good masks that actually will allow them to go ahead with home treatment. IPL is very, very expensive, so it's not for the masses. But once their lids start looking better, stay cleaner, I think overall they do get better. The kind of blepharitis you showed me, I would use azithromycin as my first drug of ointment just once a day. So that will take care of the staph. And I do tell them, it's like a lid spa. It helps you try and do it at least once a day as maintenance. So lid hygiene is a very important part if you have to stop the corneal involvement. And you will get the cornea involved because the lids do touch the cornea, and if you have a poor lid margin, the cornea is going to get affected. But no steroid for blepharitis. I don't use that.
Okay. There are definitely a lot more questions on this topic, but we'll, in view of the short of time, we'll move on to the second case scenario. 62-year-old male who is a known case of diabetes mellitus is at present moderately controlled, presents with redness, photophobia, and blurring of vision. He does give the history of episodes in the, but he is not very comfortable, is complaining of much. And there is a history of probable HZO because the patient does not say, but you do see the scars and lesions on the forehead. So at present, what we see is there is significant congestion, and we see a punched out central epithelial defect with surrounding thickened edges and edema with superficial vascularization coming in. So this is a persistent epithelial defect secondary to HZO, that's a neurotrophic cornea. So my question here would be, is there any role of, of course, we know that we have to add preservative-free lubricants here, but is there any role of steroids because there is significant inflammation around, and any role of antivirals at this stage? When will you consider doing a tarsorrhaphy? And when will you consider doing an amniotic membrane transplant? And which is less common, autologous serum, because it's not very easily available, or we don't have the logistics to prepare it. What has been your experience with it and the insulin drops topically?
So my threshold for tarsorrhaphy is very, very low. I would immediately look at tarsorrhaphy as the first option, whether it be just a lid suture, to keep the eye closed, whether it would be a botulinum toxin, whether it would be a glue tarsorrhaphy or actual suture tarsorrhaphy. There are many patients who do not take this very happily. They just feel that the eyes are not, cosmetically, they're not going to look good. But I think they have no option but to agree to undergo tarsorrhaphy. We do have autologous serum available, but I think that is then the next stage. Once you see that the ulcer has started healing, then probably keeping them on autologous serum for a longer time later is useful. If you see no improvement in the depth, or it's still a very, very indolent kind of an ulcer, you don't see anything occurring, then multi-layer multi-layer AMG would be something that I would look at. All of this, again, I think chair time is important. They have to be explained that if these are not dealt with, this is again not a vision restoration, but this is trying to prevent a perforation of these patients. And they are so symptomless because they have no corneal sensation that, they say, maybe aankh sirf laal hai. Do we have to go through all of this? And until you explain them what the morbidity of the case may be, I think it's difficult for them to agree to it very easily. But yes, tarsorrhaphy would be my first choice.
Dr. H. sir, would you differ?
Not really, because taking up the first question, I would not advocate usage of steroid or antivirals at this particular stage because this definitely looks to be neurotrophic. So usage of steroids could be a bit tricky at this point of time, and antivirals might not really help since it is at a metaherpetic stage. Tarsography definitely. I would always prefer a simple median tarsal stitch at the first instance, and they usually heal within a few days or max 1 or 2 weeks. And only if they do not, then I would perhaps consider, advising the amniotic membrane graft for them. But there are not many cases which go up to the amniotic membrane grafting stage. And I, for one, am not a very big fan of autologous serum, since I'm a bit wary of how these patients, preserve them at home. If they don't keep them in the fridge, they can turn into, it's notorious source of infection, and I would definitely want them to end up having keratitis secondary to the poor storage mechanism there. And I should admit that I'm still to use insulin eye drops for these particular conditions, and I'm quite happy, treating them with tassoraphy and rarely with amniotic membrane grafts.
How long will you keep them? And would you release the tarsorrhea at any point of time? Because patients insist on once it is healed, but then we know that it can recur.
Yes, of course. Once the tassoraphy is done, we follow them up at frequent intervals. Let's say perhaps 5 to 6 days time. And if it's a medial tarsal stitch, we can ask them to look at extreme gazes of abduction or adduction and then try to stain the epithelium and measure it as to whether it's healing or not. Once it is healed, I would like to keep the tassuraphy for perhaps even a month or so, and only then advise them and take them into confidence that if in case there are any recurrences, he might require tassuraphy, and next time would perhaps be a permanent tassuraphy. Again, depends on how bad the corneal sensations are. But otherwise, if they're pretty happy to hold on with the tassuraphy, I keep them for a month or so and later definitely remove them. And once we remove the tassuraphy, they always need to remember that they have to be kept on long-term topical lubricants, keep the surface as moist as possible, and any instance of redness, to please consider a quick visit to the cornea specialist again.
Sumit, I have one question. Whether we can use lubricants, ample lubricants, ample amount of lubricants. Second, BCL, and third, scleral contact lens in corneal lesions.
Okay.
Yes, definitely BCL could be used, but it acts as a double-edged sword because sometimes the presence of BCL itself, as we all know, that it could lead to keratitis. So one should be quite wary of usage of bandage contact lenses. If it's a very tiny persistent epithelial defects, yes, we could probably and perhaps get away with just usage of bandage contact lens and intensive topical tear substitutes. But if it's a large one, persistent, I would not prefer a bandage contact lens. I would then definitely prefer central median tarsus, which again, it depends on the presence of keratolysis. If there's mild keratolysis, yes, then we can perhaps get away with BCLs. If the keratolysis is quite advanced, let's say if it is beyond 50 to 75%, we won't want to take chance and straight away do a tassel stitch. That should be a better option.
Yeah.
I'm sorry about your third question. I didn't get that.
Yeah, scleral contact lenses in corneal lesions. What
Yes,
is the role?
they do have a major role in healing such kind of epi defects because there's a well of tears which is present beneath the scleral lenses. But more often than not, it is the accessibility and availability and affordability of the scleral contact lens which is quite a hindrance because not many patients would and can afford a scleral contact lens. At our center, perhaps if it's a Boston scleral lens, it goes up to 90K, which is certainly not really affordable. A simple single stitch in the center part of the eyelids would do the trick.
Thank you. And also, main important point is the moderately controlled diabetes. So we have to also look into that also, the strict control of sugar.
Yes.
Dr. Monica, Dr. Vishaka, this is a program for PGs, so we would definitely want to give an opportunity to ask any questions if you have. Okay.
I think they're quite clear after the webinar and they don't have any questions.
I would like to mention here, and we are still waiting for results, and hopefully we'll be able to know better. But we had a similar case, and because of hearing at different conferences after amniotic membrane graft, we have started on insulin drops because we were worried about the autologous serum and the sterility of our kind of patients where they will keep it. And actually, the defect has diminished on day 32 now, and luckily the patient is following up well, so hopefully we'll be able to, I mean, it's just anecdotal because it's one patient, but it's a good first attempt at using the insulin drops.
How do you make that insulin items?
There's a formula actually, but basically you just take the insulin, the ampule, and you make it by the formula. I don't have it at the tip of my. It's the first time we are using it.
Sir,
So.
it's 100 unit insulin. I will send you that article by Dr. Morek.
Okay.
Yeah.
Okay.
It's very easy to make in a clinic. So
Yeah, and it's quite safe
works
and
well
easy to
also.
use. Yeah, and not like, because a lot of people keep insulin and all that, especially if this patient is diabetic, probably. I don't know.
How frequently you put the drops?
Every day,
Twice.
twice they are putting.
Twice a day.
The patient is putting every day twice. We just had him visit this week, so it's day 32. We have a picture now, so and it's significantly reduced to 50%. So, but it's taking time, and he's following up well. So I think we have prevented use of steroids. So
only insulin drops and nothing else with it?
Lubricants.
No, but no tasso or anything.
No, tassography we have not done. He has good lid closure. We ask him to tape the eyes at night. That's about it.
So one very quick anecdotally, that sometimes we find that we have, we have done a couple of glue tassographies. We just use plain Fevikwik in the OPD, and very carefully. I would not let my resident do it. But when patients are very averse to, I'll stitch and also, we say, okay, we're just going to stick it down, see how you feel, come back in a few days. Don't stretch the lid margins. So that is a very cheap, quick way of actually achieving lid closure.
So what about only if you need it for a short time, because I would assume that it would.
Short time. Then they start, they recognize that the eyes are less red, they're feeling a little.
Okay. It's a good idea. I'll keep it in mind.
Is there any role of ointment?
Which ointment, sir?
Maybe your any gel, HPMC gel or ointment like antibiotic ointment?
No, so gel we use, of course, and at night especially lubricants, very copious amount of lubricants, but not antibiotic. We haven't required, at least in this one patient. Otherwise, if as required, we feel that there is some requirement, but we stay away from antibiotics for this uninfected. Yeah.
Oral doxycycline and pantagels and other things. Vitamin C drops, anything? for such non-healing epithelial defects?
We haven't used vitamin C. I don't know.
Additive, I think they would harm the patient.
Okay.
It's just supportive.
Support.
Yeah.
What has been the experience? Like some patients, what I do is I just patch the eye, put an iPad, and ask them to or change the pad every 24, especially the smaller defects, and they do pretty well. The healing is it's good and it's faster. Patients who don't want a BCL and don't want arthropathy. So, what has been the experience with just patch the eye, keep it closed for a couple of days?
I worry that they don't know how to patch very well sometimes. The eye may stay open under the patch, and then that's not good.
Chances of infections also raise, I feel.
But the temperature will be higher.
Yeah.
So unless it is only a traumatic abrasion or something like this, we don't prefer patching over a long period, even more than 2-3 days, because they end up getting infected, is what my experience is.
I think that
Sometimes patching in recurrent corneal erosions, like where we are clear that they are not infective and they have these episodes and they have a fear of using the BCL. So initially for short period we do that, but as madam told that we are fearful that they don't know to patch, so we call them at the clinic and we ourselves do it and see over a period. Then they do heal. But that is how we do it. We do it under close observation and not more than 2-3 days or so.
So sometimes if you tape the lid and then put the patch over it, and, even for overnight patching, that's useful.
What we have found is that if we ask them to tape the lids itself and send us a picture, they are more careful of how they, when the person is asleep, not awake, and we ask the close relative to send us a picture, they are a little more careful and then they continue it properly, even just the taping.
Yeah.
So I'd like to thank all of you. It was an excellent session. Like I said in the beginning, it's the learning on both sides, and
True,
that never stops.
Thank you so much for having us here.
yes, Atul sir.
Yeah.
The official.
Thank you, Nishita madam. Thank you, Yatin sir. Really grateful for you to take out the time for the younger kids, and thank you, Dr. Vishakha, Dr. Monica. I can see. I think Vishakha is giving her talk from the OPD setup. I think I saw the state line in background. So, in spite of their busy schedules, and this gives you all a practice. They reduce the phobia in exams. In our time, we don't have such anything like that. Directly present, going to the in front of examiner only. So, Asmita, thank you. You have done a very nice moderation. Thank you, the panelists, mentor madam, Dr. Sapna madam, Dr. Charuta madam. Thank you, Sumit. You are taking the too much of pains for the whole MOS PJ program. Whole and soul. Thank you, Vardhaman. Thank you, Antosh. And thank you, everyone who is here. And I hope all those who are attending found it fruitful, and it's for the members also some tips to be taken in practice. Thank you.
Thank you.
Thank you, sir, and thank
you
you,
all.
Ankur, for
Thank
all
you,
the
everyone.
Thank you, sir.
Thank you.
Thank
Good
you.
night.
Thank you.
And good night.
Good night.
Thank you, sir.